72-year-old man is evaluated in a university-affiliated nephrology clinic in the United States for progressive decline in kidney function documented over 18 months. Past medical history includes long-standing hypertension for about 20 years. He denies diabetes, gross hematuria, nephrolithiasis, rashes, arthralgias, sinus symptoms, cough, or dyspnea at rest, though he reports mild exertional shortness of breath on hills. He notes nocturia and urinary hesitancy without dysuria or fever. He takes ibuprofen intermittently for tension-type headaches. He follows a vegetarian diet and drinks little alcohol. He previously smoked 0.5 pack per day for 10 years, quit for 15 years, and for the past 10 years has smoked approximately 1 pack per day. He worked for decades as an insulation contractor with known asbestos exposure. Family history: father with hypertension who developed kidney failure in his 80s. Allergies: fish causing nausea and nickel causing contact dermatitis. Current medications: lisinopril 20 milligrams once daily, amlodipine 5 milligrams once daily, hydrochlorothiazide 25 milligrams each morning, atorvastatin 40 milligrams nightly, aspirin 81 milligrams once daily, omeprazole 20 milligrams once daily, tamsulosin 0.4 milligrams nightly, ibuprofen 400 milligrams up to 3 times daily as needed. Vital signs: blood pressure 164/86 millimeters of mercury, pulse 49 per minute, respiratory rate 14 per minute, temperature 99.1 degrees Fahrenheit, oxygen saturation 97% on room air. Examination: comfortable, fundoscopic arteriovenous nicking and copper wiring without hemorrhages or cotton wool spots, regular bradycardia with S4. Lungs clear, abdomen soft, non-tender, no bruits. No rash, perioral ulcers, synovitis, peripheral neuropathy, or edema. Digital rectal exam shows symmetrically enlarged smooth prostate. Multiple actinic keratoses on the scalp. Recent testing, past 4 weeks. Basic metabolic panel shows serum creatinine 2.8 milligrams per deciliter. 2021 CKD EPI estimated glomerular filtration rate 23 milliliters per minute per 1.73 square meters. Blood urea nitrogen 38 milligrams per deciliter. Potassium 4.8 milliequivalents per liter, bicarbonate 22 milliequivalents per liter. Urinalysis: specific gravity 1.012, trace protein 0 to 2 red blood cells per high power field, 0 to 2 white blood cells per high power field, no dysmorphic erythrocytes or cellular casts. Urine albumin to creatinine ratio 190 milligrams per gram. Urine protein to creatinine ratio 0.30 grams per gram. Renal ultrasonography: bilaterally small, diffusely echogenic kidneys with cortical thinning and poor corticomedullary differentiation. Right length 8.2 centimeters, left length 7.9 centimeters, no hydronephrosis or stones. Serologies: anti-nuclear antibody negative, anti-neutrophil cytoplasmic antibodies negative, anti-glomerular basement membrane antibody negative, C3 and C4 normal. Infectious screening: hepatitis B surface antigen and core antibody negative, hepatitis C antibody negative, human immunodeficiency virus antigen, antibody screen negative. Serum and urine protein electrophoresis with immunofixation, no monoclonal spike, serum free light chain kappa to lambda ratio normal. Coagulation and blood counts: platelets 210,000 per microliter, international normalized ratio 1.0, activated partial thromboplastin time 30 seconds. Urine culture: no growth. Hemoglobin A1C 5.9%. Lipid panel: LDL cholesterol 132 milligrams per deciliter, HDL 42 milligrams per deciliter, triglycerides 168 milligrams per deciliter. Thyroid function tests normal. Thyroid ultrasound shows a 1.2 centimeter TI-RADS3 nodule without suspicious features. Pelvic ultrasound demonstrates post-void residual urine volume 80 milliliters and mild bladder wall trabeculation. Chest radiograph reveals bilateral calcified pleural plaques consistent with prior asbestos exposure. Records from 8 years prior include a tilt table test demonstrating a cardioinhibitory response with a heart rate nadir of 29 per minute. Head computed tomography at that time was normal. Given these data, which single finding most strongly argues against performing a percutaneous native kidney biopsy at this time? Option A: continuation of low-dose aspirin 81 milligrams orally once daily in a patient with platelets 210,000 per microliter and international normalized ratio 1.0, undergoing an ultrasound-guided outpatient native kidney biopsy using current protocols. Option B, comprehensively negative immune and infection serologies, anti-nuclear antibody, anti-neutrophil cytoplasmic antibodies, anti-glomerular basement membrane with normal complement, C3C4, and negative hepatitis B, hepatitis C, and human immunodeficiency virus results before considering tissue diagnosis. Option C, urinalysis showing a bland sediment with trace protein and moderately increased albuminuria, urine albumin to creatinine ratio 190 milligrams per gram, urine protein to creatinine ratio 0.30 grams per gram without cellular casts. Option D, bilateral small, markedly echogenic kidneys 8.2 centimeters and 7.9 centimeters with cortical thinning and loss of corticomedullary differentiation on renal ultrasonography. The correct answer is option D. Bilateral small, markedly echogenic kidneys, 8.2 centimeters and 7.9 centimeters, with cortical thinning and loss of corticomedullary differentiation on renal ultrasonography. In this older man with a long trajectory of hypertension and slowly progressive kidney dysfunction, the single finding that most strongly argues against a percutaneous native kidney biopsy is bilaterally small, markedly echogenic kidneys with cortical thinning and poor corticomedullary differentiation on ultrasound. In advanced, shrunken kidneys, these imaging features reflect diffuse global glomerulosclerosis and chronic interstitial fibrosis, which not only lower histologic and diagnostic yield, but also increase the risk that any result would be non-actionable because irreversible scarring predominates. Contemporary guidance emphasizes reserving biopsy for scenarios where results are likely to change management. Small, scarred kidneys usually do not meet that threshold in the absence of a compelling, potentially treatable alternative process. The probability of sampling diagnostically useful cortex is reduced, and even when glomeruli are captured, they often show non-specific chronicity that does not alter therapy beyond optimized supportive care. By contrast, continuing low-dose aspirin 81 milligrams daily under current ultrasound-guided protocols is not a standalone contraindication in patients with normal platelets and international normalized ratio. Modern series and programmatic practices frequently proceed without interruption with close post-procedure observation. A bland urinary sediment with only trace protein and moderately increased albuminuria signals a low pretest probability of an active biopsy-responsive glomerulopathy. But in isolation, it does not make biopsy unsafe. It simply lowers potential yield. Similarly, negative immune and infection serologies neither contraindicate nor mandate biopsy. They narrow the differential but do not address safety or feasibility. In this case, the ultrasound depiction of small, thinned, diffusely echogenic kidneys is the decisive factor that most strongly argues against biopsy now. Per Kidney Disease Improving Global Outcomes 2024, Chronic Kidney Disease Guidance and Contemporary Complication Data Syntheses, the balance here favors conservative, non-invasive management and risk factor control rather than tissue diagnosis.